CP and you.
Yeah, it's we'll start, sir.
Yeah, we'll
Yes, sir.
start.
Please start.
A very good evening to one and all.
Welcome.
I heartily welcome all the members of API, ICP Karnataka, and other members of various organizations who have joined virtually from all over the country to attend this program, World Obesity Day. On this occasion, I welcome Dr. P.S. Shankar, Professor Emeritus, RGHS and KV University, Gulbarga. I welcome our own committee members, Patron Dr. Maya Sir, Dr. Suresh Sagrat, Chairman API Karnataka, Dr. Vishwanath Secretary, Dr. Ravi Kirti, and Dr. Srinivas Murthy. I welcome our today's chief guest, Professor Jyotirmay Paul, President National API from Kolkata, who was kind enough to accept the invitation and join, a great academician, researcher who has taken national API to an international level by doing great academic events, a great name in the API family in the country. I welcome our today's speaker, Professor Dr. Sarita Bajaj, endocrinologist from Prayagraj, the city which made a history and record-breaking event of conducting the Mahakumbh Mela, which attracted the whole nation. I also welcome our other speaker, Dr. Rakesh K, Director of Obesity and Metabolic Surgery from AIG Hospital, Hyderabad, headed by world-renowned gastroenterologist Dr. D. Nageshwar Reddy. I welcome our today's chief moderator, our own senior faculty, Dr. Prasanna Kumar, endocrinologist from Bangalore, who never denied our invitation at any given time, that speaks his dedication and commitment to teaching, to academics and training the youngsters. A great teacher par excellence and a researcher. I also welcome our today's panelist, Professor Dr. Anup Misra, endocrinologist. He is the Executive Chairman, Fortis Sidok Hospital for Diabetes and Allied Sciences, Delhi, a great academician and a researcher and a scholar with innumerable publications at national and international levels. I welcome our other panelist, Dr. Jayant Panda, Senior Professor from Cuttack, the past President of RSSD and other many organizations, a great faculty from Orissa. I welcome our other panelist, Dr. Shekhar, who needs no introduction, presently the Vice Chancellor of Adi Chunchanagiri University, a senior diabetologist and a great clinician. Let us not waste time by reading their CV profile, which runs in pages. Let us learn and hear from them. As I can see, many have joined virtually from many states of the country, making a national event, which COVID-19 pandemic has taught a new normal life to learn. Lastly, I welcome one and all. Now we have a formal virtual inauguration.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
We are virtually honoring all the faculty as well. Yeah. Now I request Dr. P.S. Shankar to address the gathering and for his introductory remarks.
Dr. Jyotirmay Paul, Dr. Muruganathan, Dr. Maya, Dr. Suresh, Dr. Prasanna Kumar, distinguished speakers and office bearers of the EP and ICP, Karnataka and colleagues. We have assembled here to celebrate the World Obesity Day in order to utilize the practical solutions to help people achieve and maintain a healthy weight. It is also guides them to undertake proper treatment and reverse the obesity crisis. In the recent decades, the number of obese people, that too among the youngsters, has increased. Many children and adolescents in every country are found to put on weight. And we are all aware that obesity is a major risk factor for many non-communicable diseases such as type 2 diabetes, hypertension, ischemic heart disease, stroke, and even cancer. Obesity is on rise globally, and efforts to address it are challenging due to the misconceptions about the obesity and the role it plays in personal health. World Obesity Day was founded by the World Obesity Federation with the support of the World Health Organization and the collaboration with the Lancet Commission. It was first observed in 2015, 10 years ago, and then it became an annual campaign with the goal of stimulating and supporting the the practical solutions and actions that will help people achieve and obesity as a healthy weight gain and reverse the global obesity crisis. Every year, the World Obesity Day, there is a different theme to highlight the issues related to obesity. And these themes are intended to raise awareness and encourage people to take action to prevent and treat obesity. The World Obesity Day used to be celebrated on October 11th, and then since 2020, the date has been shifted to 4th March. The theme for this year is Changing Systems, Healthier Life, and this theme highlights the need to change the system and not just the individuals to address the obesity. Obesity is a complex, multifaceted issue that cannot be addressed at individual level. Obesity affects 2 billion or more than that people, and the complexity of the condition is the challenge of the developing the lasting solutions and the burden which is being felt on individuals. It requires a social responsibility that includes radical solutions in terms of the lifestyle modifications, prevention, treatment, and attention to a healthy lifestyle. And obesity rates have uh, nearly tripled since 1975 and have increased the almost 5 times to in children and adolescents, affecting the people of all ages from all countries. It has been predicted that there will be 1.9 billion people living with obesity in 2035. In other words, 1 in 4 of us will be living with obesity, and the root cause of the obesity are complex mixture of dietary, lifestyle, genetic, psychological, socio-cultural, and economic and environmental factors. It is time we break the cycle of shame and blame and reevaluate our approach for addressing this complex global public health problem. You know, obesity is initially enviable, later it is laughable and ultimately pitiable. Obesity, defined as abnormal or excessive fat accumulation, kill more people than underweight. And the fundamental cause of obesity is an energy imbalance between the calories consumed and the calories expended. It is necessary to prevent weight gain by adopting healthy lifestyles. Highest obesity rates are found in small island nations like Nauru, Cook Islands, the Marshall Islands, Patu Islands. They have got 55% of them population there is obese. 5 most obese countries in the developing countries are the Mexico, US, Chile, Greece, and Canada, and also UK. On the other side of the spectrum, the countries such as Japan and Vietnam have lowest rate of obesity in the world. Japan has only 3.3% and Vietnam 2.1% obesity rate. Naturally, a question will be asked why it is so low. And these countries have a culture contributing factors to low rates of obesity. And there is the low consumption of the processed food. Most of the world's population is living in the countries where overweight and obesity are killing more people than underweight. People are realizing that what they eat is important. They can't put on junk food in their body and expect to be healthy. We must remember the words of Robert Updike. He said that a healthy outside starts from inside. World Obesity Day promotes resources for practical solutions that can help people to treat obesity early and avoid a healthy weight and lifestyle. And often it is said that avoid anything processed, and exercise such as a daily walk of 30 minutes can make all the difference. I congratulate the APA and ICP Karnataka and the organizers, particularly Vishwanath and Dr. Sangram, and I am happy to join the inauguration of this program. Thank you very much.
Thank you, sir, for your overview on introduction of obesity. Whole topic has been covered. I request our chairman, Dr. Suresh Agrawal, to say a few words. Unmute.
Thank you, Dr. Sangram sir, for organizing this CME on World Obesity Day. Dr. P.S. Shankar has already given a very elaborate introduction to this important issue. From APA Karnataka, we thank you for organizing this interesting program. One point to add to Dr. P.S. Shankar is the economic impact which obesity will have. By 2035, it has been estimated that almost 4 trillion US dollar economic impact it will have, which is almost equivalent to Indian economy. So we can understand how big the problem is. With this, I thank you for organizing this event, and we continue to support you in your future endeavors. Thank you, sir.
Thank you. Now I request our chief guest, Dr. Jyotirmay Paul, President API, to kindly say a few address for your inaugural address. Dr. Jyoti. Hello, Dr. Hello, Dr. Jyotirmay Paul, you are there? Because Dr. Muruganathan is on the way to join. He is busy in other meeting, probably. We will have his words of wisdom in the later on, sir. Now we move on to the scientific session. I request Dr. Prasanna Kumar sir to take over for further proceedings since all the faculty have been introduced. Over to you, sir.
Good evening, everybody. Welcome for this Obesity World Day, and I congratulate APA for conducting the symposium on obesity as such. We have a galaxy of speakers as well as galaxy of panelists. We are lucky to have all these people. The first talk will be Dr. Sarita Bajaj for 20 minutes overview of obesity. She will talk for 20 minutes because she has to go. We have 5 minutes for any questions. If you have questions, please put it in the chat box. We will answer it at the end of her talk before she leaves. Then we'll have the second speaker. And Dr. Sarita Bajaj has already been introduced. I request Dr. Sarita Bajaj to talk about obesity in overview. Over to Dr. Sarita.
Thank you. Thank you, Dr. Prasanna, for the introduction. Thank you to API and ICP Karnataka for organizing this World Obesity Day and for the invitation, Dr. Sangram Birada. Thank you. Thank you very much. I'm sharing my screen now. Visible?
Yes.
Okay, so yes. I can. Great.
Yes, visible, madam.
Yes, please go ahead.
It's not moving. Yeah, I think it's moving now. So the oldest record, just from the historical perspective, it was 30,000 BC, this famous figurine, which is the earliest example of obesity in an art form from Old Stone Age era. And this one can see in Austria. I think some of these figures have already been quoted, but I don't think there is any talk on any subject in which we do not address the prevalence as well. Of course, it has already reached alarming proportions. And in India, we have a percentage of about 46%. One of the top 5 risk factors for mortality. It was associated with almost 5 million deaths worldwide in 2019. This is the 2023 publication from ICMR in DIAB 17, in which the data, that is the projections for metabolic disease, as you can see, both generalized and abdominal obesity are at a whoppingly large number. And India at present ranks at 99th in global preparedness. US 23 billion is the economic impact of obesity in India. That was 2019. And as has been mentioned, there's a significant rise in childhood obesity as well. Again, from the ICMR and DIAB data, it is Puducherry, which has the maximum number of the highest prevalence of generalized as well as abdominal obesity, with the lowest prevalence in Jharkhand. So size matters. Anybody? Any guesses on what was her weight? She was an Egyptian. An Egyptian who was admitted in Mumbai for bariatric surgery, and she is the second highest as far as the weight record is concerned, at 500 kilograms, and she had a very, very short lifespan. But the maximum, the record for the highest weight goes to Carol Ann Yeager, 730 kilograms, and he lost the most weight by non-surgical means in the shortest documented, that is 236 kilograms in 3 months. I'm not going into the definition, let alone the only important thing to mention here is all the societies across board have now classified it as a disease. So obesity is a disease of which the etiology is multifactorial. Of course, increased energy intake, decreased energy expenditure, the hedonic input, the environment, and then we talk of the changes in the adipose tissue, pancreas, gut, genetics, and I will also be addressing some medications as well. As far as the genetic factors are concerned, there is a high heritability, and genes in the hypothalamus and leptin melanocortin pathway are important, and single nucleotide polymorphisms also predispose to obesity. So we have over 300 SNPs and over 250 loci which are associated with the obesity trait. Sociocultural factors, traditions, beliefs, peer pressure, socioeconomic factors, the food environment, availability of inexpensive, highly palatable foods. Of course, dramatic changes in the food environment, larger portions, greater meal size, stress, sleep deprivation, inactivity, all these leading to epigenetic modifications is a possibility. So now this very important consequence of the energy imbalance on the adipose tissue is what results in collection of adipose tissue or fat in the liver, the heart, the pancreas, and the kidney, which is extremely deleterious. But what happens at the level of the brain? So there is a regulation by a complex interplay of different signals and areas in the brain. Increased understanding of the biology of appetite regulation has led to the development of new generation pharmacotherapy. So this was regarding the etiology. There are several biomarkers which we can use. I've tried to list them all here. The anthropometric, which I will be going to in a little more detail. Then there are some circulating biomarkers as well. So the BMI, which was actually called Quetelet index, I'll tell you why it was named so, is the one that we use commonly. Ponderal index has also been described. Then abdominal obesity, very easy to measure by a waist circumference for intra-abdominal fat. So this will be a clinical measure. A higher metabolic and CVD risk factor is associated with this visceral obesity. And then we also take a waist to hip circumference ratio as well. So the credit goes to Adolf Quetelet for what we call actually the BMI. We do not call it the Quetelet Index. And there is a stamp in his honor as well. And he was the first to derive this equation to calculate the BMI. We can see the relationship between the BMI and increase in the cardiovascular mortality. The way it takes on once the patient goes from, say, lean to overweight to obese, and then we refer to apple or pear. We know that the apple is more harmful because of collection at the level of the waist, and it is the intra-abdominal or visceral fat which is more harmful. Just to show you that abdominal fat distribution increases the risk of coronary artery disease, and which we know very well, established since way back in 2000. Now, when we classify obesity, it is important to remember that the Asian BMI cutoffs are lower as compared to Caucasians. And you can see as the BMI increases from normal to overweight to the different classes of obesity, so does the cardiovascular risk. This is from Dr. Noop Mishra's slide, which I'm so happy to have him with us here. So there are some clinical markers which he has addressed to, like acanthosis nigricans, a buffalo hump, double chin, truncal skin fold, as well as hepatomegaly. So these are very illustrative slides showing you not only acanthosis nigricans, which is usually present in the nape of the neck or the axilla or the groin, but there are some rare sites like the knuckles and the knees as well. Skin tags are also markers. You can see skin tags here as well. They are markers of insulin resistance. So I'm now going to just mention briefly about the skin fold thickness, waist circumference, waist hip ratio I have addressed, but over and above these clinical measurements, if we still want to go into greater detail, then we can look at the bioelectrical impedance analysis, DEXA, and air displacement plethysmography. So these are more advanced techniques if we want to calculate the amount of fat. Expensive, but rarely used, more for research practices or sometimes in athletes as well. So Indians are at risk even without a higher BMI, and this is across board, whether we are in India or abroad. Ethnically, we are more susceptible. So we have a so-called, you can say, normal weight obesity, which is the actual hidden pandemic. Now, for population studies, BMI shows high specificity but low sensitivity. And this is true in elderly, where reduced lean body mass might be misclassified as a healthy BMI. So this was a very, very recent publication just last year in which they looked at the body roundness index. You can see it's a very complicated formula for calculating as far as the all-cause mortality amongst US adults. And you can see how the curve takes off with the association between body roundness index and the mortality. So if we look at the biomarkers, what is the need in clinical practice? They offer an improved, minimally invasive diagnosis, good for prognosing the patient's outcome, for predicting response to therapeutic intervention, for earlier intervention, but we still need specific data from the South Asian region. So in a nutshell, this is what I have spoken about so far, the endocrinology of obesity from bench to bedside. Consanguinity also plays a role. Consanguineous marriages, as you can see, the purple and the red and the yellow. So a lot of it in India and the neighboring countries as well. So when do we ask for a genetic test? If the age is less than 10, morbidly obese, family history of consanguinity, young onset obesity, excuse me, history of hyperphagia, mild moderate developmental delay, clinically evident visual impairment, hearing defects, or macrocephaly. See, obesity is associated with multiple comorbidities and complications, which I have tried to list here: the metabolic, the mechanical, as well as the mental. Interestingly, the obesity hypoventilation syndrome, which was called the Pickwickian syndrome, was named after Joe Pickwick, a character in this famous novel by Charles Dickens. So on the other hand, see, in our country, we are not just talking of obesity. Please remember, and this is a very, very recent from the photograph from the newspaper, in which still malnutrition is claiming lives. We are still battling with the communicable diseases. Only polio has been eradicated. The others we are still battling with day in and day out. Coming to the overview of management, like for any disease, we do first a screening and a diagnosis by taking a good history. Physical exam, I've told you some clinical markers which need to be looked into. The anthropometry, I have also addressed. Laboratory investigations, we need to look at the blood glucose parameters, the lipid panel, the liver enzymes, and uric acid. Sometimes we need to look at the cortisol as well, if you're suspecting Cushing syndrome. And we also need to look into the thyroid profile. I'm not going to address hypothyroidism here, let alone to say that even in the severest of hypothyroidism, when the TSH is whoppingly high, the maximum weight gain that you could have is about 4 to 5 kilograms. Even in morbid obesity, we find that TSH may be elevated, which is not due to hypothyroidism. Now, when we look at the 4 M's of assessment, I have addressed metabolic, mechanical, mental, and monetary also. All these need to be taken into consideration. The therapy will be guided by the degree of obesity, and there are various stages: the secured, the EOSS, and the CMDS. This is the secured model, and we look at the severity, expected prognosis, comorbid conditions, urgency of control, risk of complications, environmental factors, dysfunction, and disability. But the staging that we are now using more, which is now more popular, is the EOSS, or the Edmonton Obesity Staging System, which the significance of which is that according to the stage, you can consider the level of prevention or intervention as well. Then the CMDS staging is also described. It is, like I've already said, a chronic disease with serious implications for life expectancy as well. And people with obesity receiving the treatment are a very, very small percentage of those who actually are obese. Benefits of even 5 to 10% weight loss are enormous. So no matter how little we can expect very little and yet get good improvement, and we move on from there. So even up to 2.5%, you can see what are the effects on comorbidities. But as you go higher, of course, the advantages increase. Excuse me. Regarding medical nutrition therapy, so we look into the provision of nutritional assessment, dietary, nutritional, culinary advice, the communication, the counseling, and we look into addressing dysglycemia and adiposity through nutritional intervention. So there are 2 aims: to prevent further weight gain. That should be the first goal, and then to think of reducing even the smallest percentage that is possible. Whatever it is, whatever we do, fortunately or unfortunately, it is lifelong. As far as South Asia is concerned, there are many challenges of providing medical nutrition therapy in the South Asian scenario. There are several types of diet which I've tried to list here, which are described, but a stepwise integrated approach should be considered. The plate concept, in which you look at the vegetables, the fruits, the whole grain, and the healthy protein. And what we are these days thinking of, or should think of, is managing diet in a setting of abundance. Physical activity and lifestyle intervention have been proven to have great value. This was the Look Ahead study, which was the first RCT to address whether weight reduction combined with increased physical activity reduces cardiovascular morbidity. A paper which was just published on the 28th of February this was a Southeast Asian, African, and Middle East expert consensus on structured physical activity, dance, exercise, and sports, in which keeping that physical inactivity is a pressing public health issue globally. This was an innovative approach to address physical inactivity and promote holistic health. Monitoring is also very important, in which we assess and then we continue to monitor. Counseling and motivation are very relevant. When we come to the behavioral interventions, there's counseling, self-monitoring, stress management, apart from nutrition, physical activity, and sleep management. The drugs which are available are orlistat, cetlizumab, liraglutide, phentermine, topiramate combination is not available. Neither is naltrexone or bupropion. Semaglutide, injectable, is not available in our country. Neither is setmelanotide. Bariatric surgery, I will not be addressing. Long-term pharmacotherapy is an integral component. There are a lot of anti-obesity medications, which one needs to be aware of, from orlistat, what is the mechanism of action, the amount of weight loss, the effect on CV morbidity, mortality, the dosing, what are the adverse effects, and approval in India. So the anti-obesity medications which are available, orlistat and semaglutide, the oral tablets are available, and these are the indications in obese, BMI more than or equal to 30 kilograms, and those with some comorbidity as an adjunct to diet and physical activity for chronic weight management. This gives a very, very nice visual impression of the amount of weight loss which we can expect with different agents. As you can see, the newer molecules that are available are having a tremendous amount of weight loss, almost akin to what we would expect with bariatric surgery. The proposed mechanisms of action for phentermine, topiramate, phentermine, naltrexone, bupropion, liraglutide, semaglutide, as well as orlistat. Perhaps you've heard of Johann Hari, who has written this book, Magic Pill, which I think if one would like to know about the drugs which are meant for society's deeply dysfunctional relationship with food, weight, and the bodies. This is Johann Hari's impression. I'm not going into greater details here regarding the newer molecules, but we are still waiting to start trying them. For example, tirzepatide, cagrisema, oral semaglutide, 50 milligrams. The data is still not out. Retatrutide, amycretin, survodutide. And just to mention that, yes, there is a long list of molecules which are still in the pipeline. So I would like to end with this flow chart, that looking into the BMI, first we start lifestyle modification, then we consider the age, comorbidities which are associated, and then according to the comorbidities, we choose our molecules. Thank you. Thank you very much.
Thank you, Dr. Sarita Bajaj, for another exhaustive and also very elaborate talk about the overview. We have covered everything from genetics right up to management, drugs and all. Thank you very much. It's a very, very comprehensive one. If there are any questions in the chat box, please show me so the audience can ask the question. Meanwhile, I have few comments to make also. Not only that, obesity is an individual problem, family problem, society problem, national problem also. So what I feel, though knowledge is there, the motivation is very important. Unless you have motivation, whether drugs or diet is not going to help. What do you think, Dr. Sarita, that whether the motivation is important, drugs or diet exercise?
No, see, number one, I would rate a willingness to start losing. I think it has to come from within.
Yes.
So whether that's an individual motivation, unless that is there, and that, with different times in life, it changes. Like if you get a young person who wants to get married, is overweight, the motivation is enormous. After pregnancy, delivery, after they've had the baby and put on oodles of weight, somehow that motivation does not come back. So the motivation is first. Diet, the lifestyle is lifelong. So that is very important to build into them, that look, whatever you start, do what you will be able to do for the rest of your life. We do have medication which we can continue lifelong now, but I would still discourage dependence on them as far as possible. But then, of course, if everything has failed, we have good, excellent molecules with us and some which are in the pipeline.
Thank you, Dr. Sarita. There is a question from Dr. Sushma Tiwari. Madam, your inputs on insulin resistance and its implication on metabolic.
So, undoubtedly, the whole crux of the matter is when we talk of metabolic disorders, whether it's type 2 diabetes or whether it's non-alcoholic fatty liver disease or whether we talk of PCOS, this is actually all big one basket which we fit under metabolic disorders. Insulin resistance is the crux of the matter in all of them. Once we're able to correct, and the ways to correct insulin resistance are again lifestyle. Of course, again, we have good drugs for insulin resistance per se as well, but lifestyle and then drug support as well.
Thank you. Unless there is family support, it's very difficult to lose weight. There are emotional aspect, myth about obesity, and people with a low esteem, those who are obese, thinking people are obese are eating more. But the problem of anxiety and depression, 1 in 5 in Bangalore women are depressed. So depression is a cause of obesity. Obesity is also a cause of depression. What do you think about the emotional aspect, the social aspect, and the other psychosocial aspects, how important they are in managing obesity?
See, like when we talk of behavioral modification, I think that is what we are trying to address there. So depression, anxiety, stress, leading to overeating or comfort food or whatever we may call it, I think that's extremely relevant in today's society. So when we are depressed or when we are sitting in front of the TV, we just continue to eat. So if we define our eating timelines, and well, some people like to do intermittent fasting. Again, there are variations of doing this. Some people have tried ketogenic. But whatever it is, a ketogenic diet cannot be continued for more than 2 or 3 months. Intermittent fasting, you can continue for a long time. But again, if that suits you, if it helps you, then you have to maintain it. So the crux of the matter is the amount of calorie intake. If you can restrict your calories or maintain your calories throughout your lifespan, well, that's it. Then you've achieved your targets.
Thank you. Another problem I face is too high expectation. When they lose 3, 5, oh, this is all. I thought I will lose 20 kg. The expectation is beyond what they get. That is one of the problems we face. And the other thing is, it's easy to say lifestyle modification exercise. If you don't have environment engineering, like parks, footpaths, cycling path, why you see in Europe, a lot of them go to work on cycle. Today you will be killed if you go Bangalore or any city on cycle. Where is the footpath? Where is the cycle path? You can't even walk on the footpath. These are the problems I think we should see that the environmental factors are very good and they should be cohesive for that. For a person want to exercise or jog or walk, unless it is there, telling that you do exercise and all is very, very difficult. And as you said rightly, one can lose weight. If we do not maintain that, they come back. I've seen many of them. And what is your opinion of these crash courses, lose 5 kg, 10 kg, and all what is advertised?
I mean, I think it's all humbug. I mean, if you like absolutely, I mean, very low calorie diets will work for short term, but it will come back again. Like I said, whatever it is, it has to be lifestyle, a lifelong. And I agree. There we have good data to show that if we have parks, we have a place where we can go and walk. I know a lot of my patients, after me encouraging them, they went for a walk and they had an accident or they fell down because the roads are so bad. The footpaths are also not well made. So if they have an accident or they're hit by a vehicle, so that totally negates everything. So if the environment is friendly, it encourages you to start and then to continue the same.
Thank you very much. Dr. Sushma has said we should address it early at school or even earlier level to get the result rather than when you are already obese. Many people start when they're 80, 90 kg. Why you didn't start 60 kg? Thank you, Dr. Sarita Bajaj, for a very excellent talk and interactive one. Now we'll let you go. We move on to the next speaker, Dr. Rakesh Kalapala. As we know that he's a gastroenterologist from the Institute of Gastroenterology. He'll be talking about the future of minimal invasive therapies on obesity. Dr. Sarita, you can share the on-screen this sharing, and Dr. Rakesh will take over that. Over to Dr. Rakesh.
Thank you.
Thank you. Am I audible and my slides are visible?
Not yet.
Yeah.
She has to end the screen sharing.
Yeah, it is only Rakesh. Kindly just move slide it.
Yeah, okay.
No, it's not moving. Kindly.
1 second. I'll stop sharing and reshare again.
Now now we can see you.
Okay. So here you go. Okay.
Yes.
Okay.
Yeah, very clear. Thank you.
Okay. Perfect. Right. So at the outset, I thank APA and ICP for giving me the opportunity, especially Dr. Sangram Biradar for having me here. And I think last speaker slide has made my job easy because there are a few of the slides which my thought process is matching with the moderator as well as the last speaker. So why I'm here as a medical gastroenterologist and endoscopist is there is in obese population the lifestyle modification, pharmacotherapy, and bariatric surgery. So in between is where there is a paradigm shift in the management of obesity which happened in the last 6-7 years, and that is what is called as bariatric endoscopy. And bariatric endoscopy, though it's a little new term for many of the people, in fact, many of our gastroenterologists also are not aware of what's happening in bariatric endoscopy. But from past 7-8 years, there is a established literature on this particular entity, and this is going to be there for the next decade. And it is, I don't say it's going to replace bariatric surgery, but it is going to be complementary to both pharmacotherapy and bariatric surgery. I'll tell you how it happens. So as it was being discussed, the frequent behavior of an obese person, I never call a patient obese person as an obese patient. You should always respect them. They are obese. Of course, they must have become obese by nature or by choice or whatever it is. So they all do different types of diets as discussed before. And 95, in fact, I would say 98% of them refuse surgery when they go to bariatric surgeon. Look for magic solutions. There are so many diets in this world. Then some lose, some don't lose. Then some regain weight. And this is a vicious circle. So the reason why, I think, which has been told probably by the previous speaker, unfortunately, in this modern world, we are surrounded by obesogenic environment. And that's where easy availability of food, Swiggy, Zomato, so on and so forth, Mac, westernization of the food. In fact, I would say, unfortunately, we as Indians have adapted and adopted the westernization of American food. We should have done the European food adaptation because that is more healthy than American food. But whatever. So we have to fight with that. And if you see different departments like orthopedics and cardiology, between the conventional physiotherapy and lifestyle modification versus surgery, these two have established their own pathways, the arthroscopy and angioplasty. Likewise, in management of obesity, as I told you, between the surgeons and the physicians, endocrinologists, and the lifestyle modification specialists, we as endoscopists got into the bariatric endoscopy, which is now established evidence. So if you see this paper published in Nature in 2022, so as you see on the screen, the comparison between the lifestyle modification versus the surgical therapies, there is a lot of lull or vacuum in between. And that is a space where these endoscopic bariatric therapies have taken a big leap in the last couple of years. So if you see the bariatric endoscopy in 2024, 2025, I don't want to bore you. I'll just give you an overall view because there is so much of things happening in this in the world that there are associations which are dedicated in American Society of Gastrointestinal Endoscopy, then European Society, Asian, we'd have it in Indian. So by and large, what we have to understand is there are a couple of devices or procedures: gastric space occupying device, endoscopic suture gastroplasties, and duodenojejunal bypass liners. So what you have to understand is if you do something at the stomach level, that is what is gastric bariatric therapy, and small bowel is small bowel bariatric therapy. If you fiddle at the gastric level, it causes weight loss directly with indirect effect on the metabolic parameters. If you do something at the small bowel, then it will cause metabolic effects and indirectly a little bit of weight loss. I'll tell you why it happens. And as Dr. Sarita told, I always tell all our people who are fighting against obesity that rule of 10. You just inculcate into that person, he or she, that 10% weight loss is good enough. If you say you have to lose 25%, 30%, that fellow will say, why the hell this fellow doctor is bothering me? It's impossible to lose 25 to 30%. And if you want to lose, you have to get a bariatric surgery. I'm not going to do that. So if you tell them simple 5 to 10% is good enough, that is exactly what you have to preach for your obese patients, because it will have a positive effect from head to toe for every organ in the body. And as I told you, the interventions at the gastric level, there are a couple of things which are available. As of now, in the Indian market, we have the balloons and endoscopic sleeve gastroplasty. Balloons are again two types, which we usually do. And there are adjustable balloon and non-adjustable balloon. The data on the adjustable balloon is, there is a meta-analysis on that, so it's a proven beyond doubt. And by and large, what you have to understand is the weight loss, what you get with balloons is around 17 to 18%. And once the balloon is out of the patient, if he or she is a binge eater, they might regain weight. But till the balloon is there, then you will have around 12 to 15% weight loss. Then there are some ingestible balloons and or swallowable balloons. I'm not going into that for want of time. But there is something called as an adjustable balloon. So you must have seen in your daily practice people who have had balloons earlier, they used to put it, and then because it's intolerable, they used to take it out in day 3, day 4. But now we have adjustable balloon where you can upsize or downsize the balloon. Downsize when the patient is not tolerating so that the body gets accustomed to that. Upsize when after a certain threshold of weight loss, the patient doesn't lose weight, the obese person. So then you upsize the balloon from say 400, 500 ml to 900 ml. So the advantage of this adjustable balloon is it's got more robust weight loss than a non-adjustable balloon. And this is something which is published from a group of Mayo people in Lancet 2022, where they have shown clearly in a randomized controlled trial that adjustable balloon has got a better weight loss than a non-adjustable balloon. Again, we at our institute did a similar study on this adjustable balloon with a paired liver biopsy using endoscopic ultrasound, where we have seen that people who have got adjustable balloon with weight loss have got better improvement in terms of steatosis and fibrosis, because we obviously are the people who look on the fatty liver, and that has shown significant improvement in adjustable balloon cohort than a non-adjustable balloon cohort. And again, as I told you, if you have a meta-analysis in any procedure or anything, that means that it is proven beyond doubt in the literature. This is again for students. If anybody on the Zoom call, they can just review this AGA, the American Gastroenterology Technical Review. Coming to the other one, that is restrictive approaches. What we do, like bariatric surgeons, they do the sleeve gastrectomy. That is, they cut the stomach and make it a small size, but we don't distort the anatomy what God has given. So what we do is we do something called as endoscopic sleeve gastroplasty, where we suture the stomach, as you see on that, the definition, and then we decrease the volume of the stomach by 70%, and that leads to a decrease in the appetite. Suppose in layman language, the person is eating 2 chapati, he or she will feel full with a half chapati, and then they'll stop. So this is something which has taken a big paradigm shift in the management of obesity in terms of endoscopy. There are currently 3 devices available across the world, but we in India have got the first one, that is Apollo Overstitch, which is now marketed by Boston Scientific. So this is again a simple OPD-based outpatient procedure where we just suture the stomach and decrease the volume by 70%. Thereby, the patient will have the weight loss. And there is a randomized control trial recently published in Lancet in patients with sleeve class 1, class 2 obesity, that is between 30 to 40 BMI, where they have found profound weight loss. And the crowd with you as physicians and endocrinologists, of course, we as gastroenterologists, this is a randomized control trial where they have had one arm of lifestyle modification, one arm of ESG, that is endoscopic sleeve gastroplasty, where they found significant improvement in weight loss of around 16 to 23%. And after 52 weeks, this lifestyle modification arm has been crossed over. And then they also got the ESG, where they found the similar results. So the interesting slide for you people will be the comparison of this lifestyle arm versus ESG, where, as you see, the diabetes mellitus, metabolic syndrome, hypertension, HOMA-IR, HbA1c, the C-reactive protein, the pro-inflammatory markers, hepatic steatosis index, all have found statistical improvement. And this is a landmark trial called the MERIT trial, which has been published in Lancet 2022. And now I will say bariatric endoscopy has been accepted as a standard of care by the International Federation of Surgeons for Obesity, the largest body of bariatric surgeons in the world. And there are consensus which have been made. In fact, we are a part of the consensus guidelines which have submitted to IFSO. And this is again one similar study from our unit where we have done this ESG and then compared the obesity and hepatic steatosis fibrosis markers, where they have statistically significant improvement in these non-invasive parameters, which we quite often look upon. Then also it is helpful in many of the morbidly obese patients, though it might not give as much as weight loss as a bariatric surgery. Again, the next question is, what is the sustainability of this weight loss? You see this 2-year and 5-year follow-up from US and Spanish groups, which they have found sustained weight loss up to 15 to 17%. So comparing the endoscopic sleeve gastroplasty versus laparoscopic sleeve gastrectomy, equal efficacy, of course, between class 1 and class 2 obese people, but lesser morbidity, because if you see the sleeve gastrectomy patients, they'll have a very bad GERD post LSG if they must have come to you, because the sphincter is cut, the lower reserve sphincter is cut. But in ESG, we don't cut the sphincter, and that's the reason why the incidence of GERD is almost 0. But again, with the endocrinologist having the talk before me, so I would say that bariatric endoscopy and pharmacotherapy, they are never competitive, they're complementary. Why? Because a person, say, has got a BMI of 35, 37, 38. So they don't want bariatric surgery, nor they don't require bariatric surgery. You do this endoscopy sleeve gastroplasty, you make them lose around 15 to 17%. And if they are binge eaters, start adding this pharmacotherapy at 4th, 5th week when they start eating routine food. That will give you around 7 to 8%. It's almost 25% of weight loss you are achieving with this pharmacotherapy and endotherapy, which is equal to getting a bariatric surgery. So that's why I would say that it is a complementary therapy rather than a competitive therapy, and the world is going to shift from the bariatric surgery as a standard of care to this pharmacotherapy and endotherapy combination. So that is precisely about obesity, but just because it's a physician group, I thought let me just briefly introduce and then take you about the diabesity, the buzzword for Indian context, and being India being the diabetic capital of the world. And we as gastroenterologists or hepatologists will come and then be your trio where you have diabetes, obesity, and fatty liver, all the metabolic syndrome under one umbrella. And I don't have to talk about diabetes to your esteemed audience here. But we as gastroenterologists now propose duodenum as the epicenter for metabolic control, unlike earlier where we used to have the other organs. And the main take-home message or the pathophysiology, what you have to keep in mind is, obviously, the imbalance between the incretins and anti-incretins, which are on the brush border of the small intestine, is the main responsible factor for insulin resistance because of this imbalance. And that's where we started looking on, can you do something in the small bowel, especially the first part of duodenum and duodenum. So that is where this hypothesis of foregut and hindgut started coming into, though it is established evidence that if you bypass the proximal part of small intestine and by preventing that nutrients getting contact onto the duodenal mucosa, that will prevent the anti-incretin secretion. And if you do the hindgut hypothesis where you exclude the duodenum and proximal jejunum, that is a little more, then that will stimulate the incretin secretion. So that's where the imbalance can be balanced, and that is how you can have a positive effect on the diabesity. So bariatric surgery, beyond doubt, the Roux-en-Y gastric bypass or the ileal interposition, they all have a fantastic improvement in terms of diabetes. But again, as I told you, 1 to 2% only come onto the table. So the alternative for this bariatric surgery is where you have something you fiddle at the duodenum level. And one such thing is duodenojejunal bypass liner. It is an OPD-based device. You must have heard of endobarrier, which was there, but it took a backseat because of its side effects like liver abscess, and FDA has withdrawn. With this concept, we at AAG started working on another device of similar kind, which is a device from Minneapolis in US, which is called the duodenal sleeve, where we have a biflanged stent with a poly Teflon coated sheath, which is at 60 centimeters length, which will cover the first part of duodenum and prevent the absorption of nutrients. I'm not going to show you the video and then waste time, but as we have done the initial studies, we found that once you put this liner, there is around 1.8 to 2% HbA1c improvement with around 10 to 12% weight loss. But again, it was not that rosy as I am showing it to you. We had some issues of migration, and then we went back to benchside, did some animal studies, and then because pylorus is a very robust organ, there was migration into the distal intestine. Then we came up with solution of holding that with a few sutures, and this is one case which we have done, and we have done many more cases. The data is coming out. So this is one young lady who had a 97.5 weight with HbA1c of 8.5. We deployed this device, and within 3 months, you see there is weight loss of around 15 kgs with HbA1c improvement by 2.2%. So this is something which is big, and this is OPD-based procedure, doesn't cost much, and can be done at any average endoscopy center, and we are coming up with that in a commercial model soon. Then, if not device, then there is something where we ablate the duodenal mucosa, and there are multiple techniques which we all use in many of the surgical and other techniques like laser, radiofrequency ablation, electroporation, with steam or vapor where you ablate the mucosa and the cryoablation. One established technique which you must have heard of is the duodenal mucosal resurfacing, where you ablate the duodenum with hot water of around 90 degrees, and that creates balance between the incretins and anti-incretins but acts on the enterochromaffin cells. So that is one modality. And the another modality is electroporation, which is a little more refined technique, which again is similar kind and done endoscopically. And the other one is magnets, which is something which few surgeons are doing, but I don't want to get into that. But this is how it is done. It's a little fascinating to look upon, but you don't have to get into the crux of it. So there is duodenojejunal bypass liners or ablators will have positive effect on the glycemic control, have effect indirectly on the weight loss, and of course the cardiometabolic parameters, which we are more interested. Just to summarize, so gastric endoscopic metabolic therapies, small bowel endoscopic metabolic therapies, mechanism of action, as I told you, is a little different. But at the end, what all these modalities are going to do is have a positive effect on the trio, what I have shown before, the fatty liver disease, which we call it now as MASLD or MASH. And so just to conclude, the future is where you have this bariatric endoscopy at the small bowel or stomach level, and you have your pharmacotherapy. These two with lifestyle modification is going to give a paradigm shift in treatment of this obesity and diabetes population. And necessity is the mother of invention. That's the reason why there's so much of evolution happening in these, and we are all trying to do our bit by contributing in terms of the lifestyle wellness experts, the pharmacotherapy by physicians, endocrinologists, diabetologists, and we as endoscopists doing our bit, and of course the bariatric surgeons who are doing their bit. So again, if you want to treat obesity, or rather obesity with diabetes, it is never a single man show or a single woman show. It has to be a team effort where all these people should be under one roof and have a holistic approach of treating these patients, because this is not something where you hit only one organ. You need all these people as a multi-specialty, multidisciplinary approach to treat, and that's when you will have a successful outcome of treating a obese person. And with this, back in AAG hospitals, we have all these people under the Center for Obesity and Metabolic Therapy. And any patient who steps into our hospital will be seen by all these teams. We have a collective decision of who goes to pharmacotherapy, who goes to lifestyle, who goes to bariatric endoscopy, who goes to surgery. And this is what everybody, I insist and plead that back in your organizations, wherever you are working, form as a team like this, and then only you will have the best success. And I stop here and be happy to take any questions. Thank you very much.
Thank you, Dr. Rajesh, for an excellent presentation of minimal invasive surgery for obesity. And as you said, the last two things are very important, that it should be a team approach, not an individual, like your institute has. Medical nutrition therapy, patient can choose. He can choose drugs, he can choose surgery, or all of them can come together. Maybe medical nutrition therapy followed by medication, still not enough surgery is necessary. There is nothing like one size fits all. So it is patient choice and the surgeon choice to decide. I think, in my opinion, this is the best. You need only MNT. No, you need MNT drugs. Both of them are not sufficient. Like 500 kg, what he said, none of them are going to do. You definitely need surgery. And I've also shown us, because last time I think I heard Dr. Nageshwar Reddy, who is your director, excellent talk. Like you gave a fantastic talk about all these things, and you have also given recent things like endosleeve is said outdated and it has been disapproved by the FDA. We'll come back to you with a lot of questions. Please be part of this panel discussion. I invite other panelists to join me, Dr. Anup Mishra, Dr. Jayant Panda, and Dr. Shekhar. Please unmute yourself. Let me start with Dr. Anup Mishra. We are lucky to have Dr. Anup Mishra because if you see one person who has published maximum about obesity, metabolic syndrome from India, it is Dr. Anup Mishra. It is 40 years of research, teaching, patient care. And he is the only Indian in the Lancet Commission, what Dr. Chairman was telling us, Dr. Shankar, and also Sangram Biradar. And we are lucky to have him. And I want to ask him that if he can go on 1 hour, we can discuss that Lancet Commission. I mean, there is so much of new information, new definition, but I would like to start asking him, what is the new definition of obesity by Lancet Commission? How do you clinically make out preclinical or clinical? What is the importance, Dr. Anup Mishra?
Thank you. First of all, let me thank Dr. Sangram for inviting me here, and thank you, Dr. Prasanna, for mentioning this very important point. We deliberated over 1.5 years, 57 people. Every week we had teleconference for 1.5 hours, 2 hours, to know how best we can tackle this very complex subject. It was exceedingly difficult to arrive at a consensus, and there were so many people who were against a particular line of reasoning, and other people were watching very strongly. We invited several experts who are not the commissioners, and one of them was what Sarita was mentioning, Dr. Arya Sharma of Edmonton Staging Frame. We did the Delphi method of consensus. What was thought was that while the earlier definitions by WHO were using BMI as the criteria for categorizing obesity and overweight, there is now more information about how faulty the BMI can be in certain situations, not all, but certain situations. And that the abdominal obesity is perhaps a more important parameter. And we discussed at length about waist circumference, waist hip ratio, and also waist height ratio. So it was felt that those who have more abdominal or adiposity or increased body fat, these are the people which should be actually termed as obese. But then not everybody with abdominal adiposity or increased body fat has a adipose tissue which is going to cause problem. It may be healthier adipose tissue also. However, this is not so true as far as the Indian population is concerned, as we have done a number of studies on this. So it was decided to bifurcate the classification into two. One, the preclinical obesity and a clinical obesity. Preclinical obesity is not a disease, it just excess adiposity and without any consequences of it, meaning that this person does not have any metabolic consequences or mechanical consequences. So, he does not suffer from knee pain, hip pain, and does not suffer from any obesity associated diseases. Such a person needs careful counseling on the diet and exercise, but does not possibly need a pharmacotherapy, though his BMI may still be high or abdominal adiposity is present. On the other hand, somebody who has a BMI of, say, 29, has a waist circumference of 120 centimeters, waist height ratio, which is 0.6 or 0.7, and has, say, for example, non-alcoholic fatty liver disease or MSLD, obstructive sleep apnea, and has a joint pain. This person needs aggressive therapy. So this is the kind of bifurcation of preclinical and clinical obesity that we felt was reasonable. At the same time, Dr. Prasanna, we also, aligning with the Lancet, we published a paper on Indians' new classification for Indian population, which is similar, nothing much different, except that we didn't want to copy exact terms of preclinical and clinical obesity, which I thought was not very, very convincing way of classifying. So we classified in stage 1 and stage 2. And anybody interested in that particular paper, I can send you this paper. I circulated again this morning. The question was, say, a person who are the people who will need aggressive therapy, GLP-1 receptor analogs,
or bariatric surgery versus those who do not. And we just watch this. So this is the kind of scenario, Dr. Prasanna, at this point of time. I hope people realize that this is a reasonable system and prognostication is very well done with this kind of system, and resource allocation is also reasonably done.
Thank you very much. Anybody, clinician interested in obesity should read this Lancet Commission, which was published March 2025. And it is available, the whole thing. What all you discussed is there. As you said, people meet, agree to disagree. Opinions may be different, but a consensus statement has been made. You may have slight changes, Asian population, African, American, and all. Rightly, as you said, from that, because you are the only representative from India, so you can suggest some of the changes which are probably acceptable, adaptable, and also accessible to them rather than blindly following that. I also want to ask one thing, because you are speaking at a national level, international level. Now that country has made a commission for obesity. There are film actors, philanthropists, and there are technical people. What do you suggest? As I know, there are no doctors in that group. As a doctor, what will you suggest this National Commission on Obesity, what they should focus on? Is it individual, society, state, country, children, adults? What is your suggestion to this group?
I have already been approached by the government, Dr. Vinod Paul, who's a member of Planning Commission or Niti Aayog, and we both discussed this exactly the same question, a very important question, and we arrived at the one common minimum sort of a program which should be addressed or which should be taken forward is the focus on childhood obesity. I think this is terribly important to focus at early age, and we earlier had a paper in British Journal of Nutrition where we looked at the messages that can be absorbed, and then people, which are the children who act upon these messages of healthy living, a healthy diet, and healthy exercise, and so on, are the children who are below 10 years of age. And the moment they go beyond this, they have developed habits which are slightly difficult to let go. So I think from a very early age, we have to teach the children and make them practice. Not teaching is not enough. Make them practice, and their environment of school and home also should be healthier. So this is what focus of our previous programs on obesity was, and this is what we discussed with Dr. Paul, and we are going to share with him all the data from India, and hopefully with the good messages from our Honorable Prime Minister, we should be able to act on them.
But Dr. Anup, there is a paradox. All the state governments are focusing on improving nutrition in the children. You have got all the rural government schools, they are all undernourished. Anemia, 30% girls. On the other side, come to cities and you have got private schools where your problem of obesity is there. So you should have two things. Still, many states are not able to take out malnutrition. And if you take the hungry index, India is 129, probably one of the lowest after Africa. So we have that big problem. You can't say that everybody is obese in children. Then you have problem of cities where you see private school, obesity is 20-30% of all these things. So how to operate two programs exactly dialectically opposite, nutrition therapy and giving the better nutrition, better protein, fat, and the calories even. On the other side, obesity.
See, this is it's an operational problem, but it can be solved very well. A healthy diet is both for undernutrition as well as for overnutrition. And if we teach them what are the, you have to take plenty of fruits, vegetables, salad, less of oils and things like that, that works both ways, for undernutrition also, for overnutrition also. However, you're right. Those who are markedly undernourished, we have to increase the calories, and we have to take a special care of them by increasing their protein intake and things like that. And so the focused area should be there. that this is a focus undernutrition in certain areas and overnutrition in certain areas. For example, Delhi, even in the public in the public school, government school, the obesity is increasing. However, as you rightly said, there is a big gap between the government schools and the public schools. And the farther you go away from Delhi, the more the undernutrition comes in. So this, government has to balance this the programs, how to tackle these both areas. And if you see the recent data publication, undernutrition is going down and overnutrition is going up. Has been the secular trend, and I'm sure with the program for undernutrition running for a couple of decades, we will have less of undernutrition in the future, but overnutrition will increase further as the data indicates.
Thank you very much. I hope your wisdom experience will be useful. You will be inducted into that national obesity with the data about children and adults and what are the intervention. I think a doctor like you with a scientist like you is there, apart from nutritionist and all, it will go a long way in preventing obesity. Thank you very much. I'll come back to you again if you are there.
Thank you.
Let's move to two clinicians, Dr. M.A. Shekhar, he is the Vice Chancellor of University, Professor of Medicine. Shekhar, in your day-to-day practice, when you see obesity, not necessarily diabetes, cardiovascular, everything you see, how do you identify obese people in your clinic, not the theory aspect and other things? And what do you do at your level as a physician to solve the problem of obesity?
Oh, thank you for this opportunity to be a part of this, ecclesial group. And the question is such an extraordinary question. I really have to think twice before answering. But you have clinical practice. In clinic, do we go about doing a lot of tests? Do we just look at the patient and decide whether they're obese or not? Or do we have anything else? Sir, if you can give me the latitude, I would like to do it in a different manner. We have been talking very, 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 vociferously and scientifically about why people become obese. A lot of things are happening, but we have never ever have had very practical output when it comes to obesity. We know so-called subcutaneous fat, etc. So eyeball assessment of obesity. We know waist-hip ratio, neck height ratio, all those ratios that we can, anthropometric, which makes visceral obesity a very important factor. But we also know, though we are lean, though we do not eat much, there is what is called as metabolic obesity. This is where I differ with many of the clinicians. Unfortunately, we rely heavily on all those parameters of anthropometric activity and then metabolic, disturbances. But in my clinical practice, since it is walled off to only diabetes mainly, when I look at a patient who, rather, we should not say patients, persons with diabetes, whatever you would like to, let's be a little bit clear about it. When they sit in front of me, male, female, whatever it is, including their attenders, the first thing I feel is potentially they are all obese. Whether they are physically obese, viscerally obese, or metabolically obese, we really have to look at it. This is the first step I take, sir. So potentially they are obese. Let's look at it in a different way. Now, when I have, made it the so-called KISS principle of keep it simple, the issues of why people become obese, let's not look at their milieu interior, let's not look at their physical environment and all that. I have broken down it into two. I hope it will be taken in the right manner. The first one is energy balance model. Put all these things in that one basket of energy balance model where carbohydrate insulin model is the next one. So energy balance model, we talk about caloric intake, whether it is carbohydrate, fat or protein, and physical activity and metabolism that we are looking at, derangements, whatever, insulin resistance, everything has come in. The second one is carbohydrate insulin model. In other words, the amount of everybody is talking about eat less carbohydrate, and all sorts of fad concepts of food has crept in. But I would like to, convince the youngsters listening to us, it's the carbohydrate that makes a lot of insulin production in the early periods when they are not diabetics. And it's the carbohydrate intake that leads to obesity. Fat and protein may not have that massive intake. More carbohydrates, more insulin, simple, practical model, energy balance model. You eat, you exercise, you have a good metabolism, liver function is good, etc. I don't think we will be obese. But there is this breakdown of energy balance, and there is this unfortunate tipping of carbohydrate insulin that leads to obesity. This is my practicality. So when I look at my patient, either they are energy imbalance or they have an insulin dysfunction or whichever hormone you would like to bring in. The second one I always think about before I start treating, let me tell you about that, is the determinants of nutritional imbalance. Professor Anup has beautifully spoken about under and over nutrition, and you, my mentor for the last 35 years, always talk about undernutrition, which is much more important, which makes them obese after 20 years. Undernutrition in childhood invariably leads to overnutrition once they start, making money for themselves. This is where we have to focus. And I feel we really have to look at determinants of nutritional imbalance, especially so in India. And I have broken down it into, the first one is how, our home contextual factors. We all know I come from a joint family. I do not have a joint family now. So this is where the first start, nuclear family concept, where time-constrained parents have no other choice but to make their children, please don't mistake me, make their children obese. Both parents are working. They have no time to look after their children's nutrition. They allow them, guilt-ridden, they allow them to eat whatever. This is the first contextual factor. The second one is peer influence and socio-cultural environment. Peer influence is simple. Somebody calls me for a marriage or some function. If I don't go, they get upset. When I go, I have no other choice but to eat. And whoever is sitting in and around, they say, why don't you eat, sir? Nothing will happen. Peer influence is another major issue. Forget about metabolism and insulin carbohydrate activity and socio-cultural, environment. We were talking about, during our independence, we did not have 1 square meal a day. Even the poorest of the poor have at least 2 square meals a day, which may not be nutritious. The third one is business and neighborhood environment. Business models. You see any movie or any, serial, there is so much food on the table and hardly anybody eats it. There is a subliminal message that you don't eat much. But looking at that, so much of food, we get, excited. And the business model is they start making a lot of these foods outside and we have no other choice but go to taste it. And the neighborhood environment. The neighborhood, I talk about our own family, our own people, and then at the end of the day, the country. So I keep these 3 household contextual factors. I ask them, who cooks for you? What are the components that you eat? Peer influence, do you frequently, how many times in a month you eat out? How many marriages and other functions? This is the way I look at it. Once I get an idea, the simplest concept is exercise, eat less, more of, I have made it a pyramid concept. I hope it is taken well. More of vegetables, less of carbohydrates, little of oil, and zero sugar or zero jaggery, whatever it is. I just tell them, and it does not work in the first sitting, second sitting, and all that. That change, behavioral change shall occur after 6 months of constant telling them, what we call as andragogy. This is my take on what I do with my patients who sit in front of me. Number one, I think potentially they are all obese, whatever level, metabolic obesity, visceral obesity, or whatever. Then I look at whether they have energy balance model that's working for obesity, or carbohydrate insulin, or food model with hormones put in. Whatever hormones you want to talk, I just gave you a concept of insulin. And then those factors for nutritional imbalance. This is how we look at it. And it's, as Professor Sarita was talking, it's a lifelong activity. I hope I made myself clear.
Thank you very much. As you said, from independence, you have green revolution, IT revolution, BT revolution. Now eating revolution is going on. And that is why all over the place, it's probably a culture. Thank you very much. We move on to Dr. Jayant Panda. Dr. Jayant, you're there? Yes, Dr. Jayant, you please unmute. Can you hear me? Please
Somebody has to unmute him.
Please unmute.
I think the admin should unmute him, sir.
Oh, yes, maybe. Can you unmute Dr. Jayant Panda? He must have entered.
He is unmuted now.
Okay. No, he has not done it.
Now you are unmuted, Jayant.
Yes. There,
So
actually,
my
thank
question
you.
is, yeah.
Yeah, thank you, sir.
Is,
Thank you, Prasanna Kumar, sir, and Professor Anup Mishra, sir, and Dr. Shekhar, Dr. Shangram, Sarita ma'am, Rakesh, and Jyoti, and the whole team who are here. Actually, today, listening so many facts and the messages, we have become wiser. And what we are thinking, I have been listening Dr. Anup Mishra for last 2 decades, since 2000, on obesity. So many things have changed, and the big epidemic has engulfed the whole world. The tsunami has responsible for creating a host of metabolic challenges, including diabetes, hypertension, and the dyslipidemia, and the cardiovascular, neurological, as well as the peripheral vascular catastrophes have taken place. So if you see today, a single risk factor for maximum diseases in the world around is obesity. So rightly we have celebrated. I congratulate API and ICP Karnataka for this beautiful CME, which has made me wiser than listening to big brains working on obesity. Just one thing I'll tell, the management, in management there are many things. We heard about restrictive surgery, about the decreasing the surface area. We heard about the GLP-1, GIP. We heard about the different medical interventions, but the secret remains one, which we promote in diabetes remission, which we promote in the blood pressure control, which we promote in any metabolic disease, is the lifestyle. So that's my message. Why to bring a problem and why to be after that to solve it. So let us promote lifestyle by ourselves, by our governments, by our people at the grassroots level. And as discussed, the childhood obesity has become just very conspicuous in the schools. Any well-to-do school you go, you'll see more than 50% children are obese. Previously, 5 to 10%, even 15% we are seeing. So children are more weak for the food, and they just don't take any suggestion, and they go on taking. So after lot many discussion, we concluded what traditionally our forefather were doing, taking complex carbohydrates, taking more fiber, taking low glycemic index food. They didn't know about these factors, but what they were eating, what they were doing, more work and the very healthy food that can only protect our families, our society, our country. And even it has gone to the Prime Minister in Man Ki Baat, as all of you have heard. It has become a national concern that the weight of the country is increasing, and India, not only in diabetes or the heart attack, in obesity also is going to be the global capital. So let us, all of us together, start a movement of lifestyle. The drugs and the surgery are there definitely for an option for those who need, who can afford, and who want to go for that. But lifestyle promotion at our end, ourselves, our family, our society, our organizations, our government is a must for all of us who foresee a dark future for the country with such a rate of weight increase and tsunami of metabolic problems. Thank you again for giving me an opportunity. I'm very proud that it's not by RSSDI or Arrow. The API ICP have taken up this big issue with so much of discussion, and will also being the largest physician body in the country will also promote this, and I'm sure with our effort will be successful. Thank you again.
Thank you, Dr. Jayant Panda. There is a question to Rakesh. This question is, thank you, sir, for a comprehensive PPT. This is from Dr. Sushma Tiwari. With decrease in appetite to about 70%, how do we maintain the RDA, and is giving synthetic supplements the only alternative to a balanced diet in such cases? Dr. Rakesh, please.
Yeah, it's a very good question. So what we are doing is, though we are reducing the volume by 70%, we are not altering the anatomy. The absorption capacity of the stomach remains intact. There is no change in absorption. And we don't, in fact, give any supplements like B12 or iron and all. Unlike surgery, you're not chopping the stomach off. The stomach is there, but only thing is the volume is getting reduced. But the mucosal absorption will remain as it is before and after the procedure.
So I think with this, we have just completed the time. I would like to thank all the participant panelists and the speakers, Rakesh, Dr. Sarita, Dr. Anup Mishra, Jayant Panda, and Dr. M.A. Shekhar. Above all, I would like to thank API and ICP, and in special, Dr. Sangram Biradar for inviting me to moderate this excellent session where I learned a lot from all of you. Thank you very much. Thanks all the audience for the interaction. And I would like to hand it over to Dr. Sangram Biradar to close right on time.
Thank you, sir. Thank you, one and all. Before we conclude, I request Dr. Vishwanath to propose the vote of thanks.
Good evening, sir. Very thanks to all the speakers. It was an excellent session, as I think as we conclude. Professor Sarita Bajaj and Dr. Rakesh, thank you for that excellent lectures. And special thanks to Dr. Prasanna Kumar, sir, for moderating a very important session. And as usual, sir, you were crisp. I also thank Dr. Shekhar. Always you keep it simple, but you give us so much information. Special thanks to Dr. Jayant Panda, sir, for the concluding remarks. I think we are moving beyond BMI. Clinical obesity, I think, is something new we are talking now. So, of course, it was always a pleasure listening to Dr. Anup. As Dr. Panda said, each time we listen to him, we become wiser. I think for the last so many years, we are listening to him. Such a great person with regard to this topic. I thank Dr. Biradar, as usual, to bringing all galaxy of speakers to this, and also thank our chairman. Thank you, sir. Thank you once again. Thank you all.
Thank you. Good night. Take care.
Yeah, thank you, one and all. Before we sign out, good night.
Good night.
Good night. Thank you. Take care.
Thank you, everyone. Thank you, everyone.
Thank you, sir.